Dr. Meghna Matthew, working as consultant in critical care unit in pulmonary medicine in Apollo First Med hospitals. My task for the day is to cover urinary tract infection. I intend to take you through definition, the spectrum of illness, diagnosis, and treatment modalities. Now let me go through the definition of urinary tract infection. The definition of urinary tract infection includes any symptomatic infection that occurs along the urinary tract, including the lower or upper, and can be classified as complicated or uncomplicated. This particular slide shows you the picture of the urinary tract. It includes the urethra, the bladder, the ureter, as well as the kidneys. The infection of urinary tract usually starts off with the lower urinary tract, where there is colonization of the lower urinary tract, especially the urethra. The pathogens, once gain access into the urinary tract through the urethra, can ascend up into the bladder, resulting in cystitis. If the infection is not controlled at this particular point, it can ascend even higher, resulting in the infection of the kidneys and the ureter, which we call as pyelonephritis. Now, since we are through the definition of urinary tract infection, let me take you through the symptoms and signs of urinary tract infection. The most common symptoms are patients might complain to you of dysuria, they might complain to you of increased urgency, hesitancy of urination. They might even complain of abdominal pain. On examination, you might find sometimes loin tenderness. The other most common symptoms are how they present to you would be fever with systemic signs and symptoms of chills, rigors. Pertaining to men specifically, they might complain of even pelvic or perineal pain. Once we are through the definition and you know the signs and symptoms of urinary tract infection, you also need to establish your diagnosis. So what are the key investigations that you would be sending off? You would want to consider sending urine microscopy. You would want a urine gram stain, a urine routine, urine culture and sensitivity. Even imaging, including an ultrasound and CT, plays a key role in diagnosis of hydrohydronephrosis or pyelonephritis. There are some additional tests like urine dipstick leukocyte esterase test and urine nitrite test, which may not be very sensitive and specific. That's because in a urine nitrite test, if you don't have a bacteria which is converting the nitrate to nitrite, your test may be falsely negative. For urine microscopy routine or gram stain and even culture, you need to advise your patient on how to collect the urine specimen. It is preferable to always have an early morning sample. You need to tell your patient that he or she needs to completely void before going to sleep, and the first sample in the morning can be collected. Random urine sample can also be collected. There is no hindrance to it. However, once the sample is collected, there should not be more than 2 hours delay between the collection of sample and the processing of the sample in the laboratory. For sending a urine routine, micro, gram stain and even culture, you need to explain your patient how to take the urine specimen. It has to be a midstream clean cat specimen. For females, it has to be clean from front to back and hold the labia apart for collection. For men, you have to clean the end of penis in a circular motion and then the sample has to be taken. The first few dribbles of urine can be ignored and then the sample connected. So what are the most common bacteria that causes urinary tract infection? The most common cause, the chunk of the urinary tract infection, is caused by Enterobacteriaceae, which includes Escherichia coli, which is nearly 70%, following which you can have Klebsiella pneumoniae, Proteus mirabilis. The other rare organisms are Enterococcus. You can have Staphylococcus saprophyticus. Now, other than knowing the microbes, you also need to know the antimicrobial susceptibility pattern, as in to which particular antibiotics these particular microbes will be effective against. Now, the reason is because of the ESBL, the rising emergence of the ESBL, extended spectrum beta-lactamase. So what is extended spectrum beta-lactamase? Extended spectrum beta-lactamase are those organisms that generates beta-lactamase, and it can be resistant to any third generation cephalosporin or monobacterium. Third generation cephalosporins being cefotaxime, ceftriaxone, ceftazidime and then aztreonam. Now, since we know and we have established the diagnosis of urinary tract infection, you would have set a urine gram stain routine culture, we need to start the therapy, and that is called as empiric therapy. The empiric therapy depends upon multiple factors. It depends upon the severity of the illness. It depends on if you're covering a resistant pathogen. It depends upon the host factor. Host factor as in, was the patient any time in the recent past exposed to any particular antibiotic? What is the immune level of the patient? Is the patient on certain drugs which can affect the immunity? So what does your empiric therapy for acute uncomplicated cystitis consists of? It consists of you might want to consider giving the patient nitrofurantoin 100 mg twice daily for 5 days, or you want to consider trimethoprim sulfamethoxazole in the dose of 1 double strength tablet twice daily for 3 days, or beta-lactam or fluoroquinolone can also be considered. The reason that fluoroquinolones is not very much accepted is the emerging amount of resistance seen to fluoroquinolones. If at all the urine culture shows a bug which is sensitive to fluoroquinolones, you might consider giving them ciprofloxacin 500 mg BD or levofloxacin in the dose of 750 mg OD. Now, since we are through the empiric therapy of acute uncomplicated cystitis, let us go through certain complicated cases. What if your patient is admitted and not critically ill? You might want to consider using a third generation cephalosporin, and that would be injection ceftriaxone in the dose of 1 gram once daily. Or you might even consider piperacillin tazobactam in the dose of 4.5 grams every 6 hourly to even 8 hourly. There are certain other alternatives like oral or IV, intravenous, fluoroquinolones can also be used. The same ciprofloxacin or levofloxacin can also be used, provided the amount of resistance in your local area is not exceeding 10%. The choice of empiric therapy of antibiotic in a patient who is critically ill or has got a complicated urinary tract infection would be to consider carbapenem. Carbapenem includes meropenem in the dose of 1 gram every 8 hourly or imipenem in the dose of 500 milligrams every 6 hourly. This is to cover the extended spectrum beta-lactamase. You might want also to consider covering MRSA, which is methicillin-resistant Staphylococcus aureus in a patient who is critically ill or has got a complicated urinary tract infection. The drug of choice would be vancomycin. The other alternatives are daptomycin and linezolid. Once the empiric therapy for urinary tract infection has been instituted, you also need to get back your urine culture and sensitivity report. This results of the urine culture and sensitivity should be followed. This is to ensure that the chosen empiric antimicrobial regimen is appropriate and to guide the selection of definitive therapy. There are conditions when you see the patient is not having any symptoms, but your urine culture and sensitivity shows certain bacteria growing. And there are conditions when you would want to address the same. Those are someone who is pregnant, a patient who has undergone an invasive urological procedure, or a post-renal transplant patient. So why are not all cases of asymptomatic bacteriuria treated? These are for the following reasons. It results in only temporary eradication with subsequent recolonization. It can be associated with antibiotic-related adverse effects and side effects. It can result in emergence of antibiotic resistance. It can cause recurrent asymptomatic bacteriuria. It doesn't affect the frequency of symptomatic infection, including pyelonephritis. So let me summarize the talk for today. I was talking to you about today urinary tract infection, which is basically any symptomatic infection of the urinary tract, be it the lower urinary tract or the upper urinary tract. Remember the signs and symptoms that I had told you about. Remember how to establish the diagnosis, urine microscopy, urine gram stain, urine culture and sensitivity, and consider getting an imaging. What about the treatment? The treatment will be as outpatient in uncomplicated cystitis. If someone is critically ill and is in ICU, you want to cover with broad spectrum antibiotic, including the cover for ESBL, that is with carbapenem, as well as MRSA cover. Someone who is not critically ill, you might want to consider simply giving ceftriaxone or piperacillin tazobactam, or even IV or oral fluoroquinolones can be considered. Remember always to de-escalate the antibiotics at the earliest. This is to prevent the emergence of resistance. And with that, I would like to conclude the talk for today, which was on urinary tract infection. The intention was that you all, the future practitioners for tomorrow, have a clear idea how to treat a urinary tract infection. Because you being the future for tomorrow, it's very important that you all know how to treat a simple urinary tract infection. The emergence of resistance in our community is very high. And for that matters, I wanted to keep it as simple as possible and reach across to all of you so that you have a clear and concise idea in how to treat a urinary tract infection. Thank you.